So, as the name suggests, this is treatment that the patient did not want, but the patient got this treatment anyway, right? Obviously, intuitively, that's a problem. There are three different types, at least three different types of unwanted medical treatment, and I want to distinguish them. So, the first type of unwanted medical treatment is this. This would be treatment that it's really not even medically indicated, right? So, there's not even a scientific or clinical basis for providing the treatment at hand. So, some examples of this, just from the recent news, would be this breast surgeon who was jailed for 15 years for doing needless operations that these women did not even need. Also, this is a cancer physician in Michigan who was sentenced to 45 years in prison for things like giving patients chemotherapy when they did not even have cancer. And then similarly, this physician sentenced to 20 years for doing inserting cardiac stents in patients when they didn't even have blockage right in that vessel, right? They didn't need it. So this is pretty, these sorts of cases, and we could find 50 more just from the past 10 days, but these sorts of cases are pretty black and white. It's just the procedure that was actually given to the patient just definitely wasn't needed at all. There are, of course, a whole bunch of other procedures that we see the headlines almost daily saying, 30% of this type of intervention is unnecessary, 50% of this is unnecessary. Um, and the problem there is there's not a consensus about what is or is not necessary with respect to a whole bunch of interventions. So I'll put those aside. Because there's internal variability within the medical profession about those ones. So just want to keep with the crisp and clear cases where it's definitely outside the scope of what's indicated. Right, and this is just one example, right? We do 700,000 stents a year, and there are reports that maybe half of those are unnecessary. But that's because there's a dispute about how much of a blockage is such that it warrants the use of a stent. So I'm not talking about where there's disputes within medicine about what is or is not medically necessary. I'm just talking about cases where everybody agrees this is in the not necessary category. Spinal fusions. And anyway, there's lots of stuff that we think we overdo. So probably some degree of that is definitely unnecessary. But again, just for the sake of simplicity, we'll leave that aside. So what we're talking about here in this first of three types of unwanted medical treatment are instances where the treatment is just definitely outside the scope or universe of what is medically indicated. No patient would want it because these things all entail risks by doing the operation or administering chemotherapy, but offer no benefits. So who would want something that's all risk, no benefit? So the claims or the legal theory on which these physicians were convicted and usually are convicted is fraud, right? Federal healthcare fraud. The second type of unwanted medical treatment is this. Now, what we're going to talk about is treatment that is indicated, right? There is a medical, clinical, scientific basis for giving this treatment to this patient with this condition. But it may not be the case that the patient wants the treatment. Usually, people do want things that would be medically indicated, but not always, because it's not just all benefit. There are risks too, and different people will trade those off and balance them differently. So, again, the second type, we're now talking about treatment that is clinically indicated, but is not preference indicated. In other words, we can look at the patient's body and think, oh, this procedure would be appropriate or relevant for the condition that your body is in. But we also need to look not just at the patient's body, but at the patient's mind, or at least at their will, at their preferences, and diagnose that as well as diagnosing their body. And when we do that, we find in this second type of unwanted medical treatment that they don't want it. So the reasonable patient might want it because there is a basis for it. It offers a prospect for benefit. But this particular patient does not. So let me just give you three quick examples of this. One would just be going outside the scope of consent. And we talked about this briefly when we talked about battery, the medical battery claim, right before we talked about informed consent. Right, so the Schlondorf case, the patient consented to a biopsy of this tumor, but not to removal of the tumor. Physicians went ahead and removed the tumor, going outside and beyond the scope of her consent, doing a different procedure than the one she consented to. Right, the Moore case, right, where it wasn't a different procedure. It was the same procedure that she consented to, but it was done to a different part of the body than she had consented to. So again, outside, what the physician did was outside the scope of the patient's consent. Some other recent cases involve advance directives, right? So we try to encourage people to complete advance directives so we know what they will want or won't want when they lack capacity to tell us themselves. So this woman in Georgia did this, said she would not want to be intubated and put on mechanical ventilation. What happened? She's at the hospital, she's intubated, and she's put on mechanical ventilation. She sues, and ultimately the case settles for $1 million. Again, primarily on basically a medical battery claim. Another thing that we're seeing in courts across the country, New York to LA, are forced cesareans. So these are women who, again, there's a medical reason, right, for the physician to recommend a cesarean because of some risk to the fetus, for example. Nevertheless, the woman wants to have a vaginal birth, is willing to accept the risks, but the physician proceeds and does the cesarean anyway. Again, unwanted treatment. Pretty crisp, clear, especially when the woman is saying, no, don't do this, and they do it anyway. I don't want X. What does the clinician do? X, the very thing that the patient said she didn't want. Now, of course, these sorts of explicit refusals constitute only a really small fraction of unwanted medical treatment. In those cases, right, unwanted intubation, unwanted cesarean, and so forth, right, the claim, the lead legal theory that's used there is medical battery. So in type 1, we have no medical basis for the treatment. In type 2, we do have a medical basis for the treatment, but the treatment has been rejected by the patient. In type 3 now, we're going to the third type of unwanted medical treatment. This is the most common type of unwanted medical treatment by far. Here, there hasn't been any rejection, there hasn't been any refusal by the patient of the treatment at hand. In fact, there's actually been consent. The patient has actually said, "Yes, I want this treatment. Give it to me." The problem is that when the patient does that and offers that consent, gives that consent, the patient is uninformed. So if I went to Starbucks, right, and ordered this caramel mocha frappuccino, that's what I ordered and that's what I received, then everything looks hunky-dory, right? Because it looks like, well, I got exactly the thing that I ordered. It matches, so that symmetry looks good. The problem, though, is even though I got what I asked for, the problem is this: I didn't really know what I was that I was ordering or receiving. I didn't know, for example, that it contained 75 grams of sugar. And the nature of the problem is that that's pretty significant. And had I known that this drink contained 75 grams of sugar, I wouldn't have ordered it and I would have ordered something else, like maybe a plain black coffee instead. I would not have consented if I knew the risks, benefits, and alternatives. So this is the nature of an informed consent claim, right? I did get what I asked for, but I didn't know some important feature of the thing that I asked for. And had I known that feature, I wouldn't have asked for it.